Hello everyone. Today we will be going to start with a new topic that is inflammatory bowel disease. So we divided this gastroenterology into two parts. First is the basic diseases and then there is core part of the disease. And now we are moving to the core part from this lecture. The 4 5 lectures which will be coming upcoming lectures. You will see the core part of this involvement of the gastrointestinal tract. So first is the inflammatory bowel disease. What is inflammatory bowel disease first of all? So there will be inflammation in the intestinal tract, gastrointestinal tract due to the immune response in genetically susceptible individuals. There will be autoimmunity, there will be defecting gene, there will be exogenous endogenous factors which will be affecting this thing and it will be cause inflammatory bowel disease. What are the entities of inflammatory bowel disease? The entities are first is the ulcerative colitis, then the Crohn's disease, microscopic colitis, and divergent colitis. First, we'll move on with the microscopic colitis because it is short and sweet. Then divergent colitis. After that, we'll move to the differences between the ulcerative colitis, the Crohn's disease, and the pathogenesis of ulcerative colitis, Crohn's disease, and then there will be the pathology of there and some clinical factors. That's it. First, entities of inflammatory bowel disease, that is ulcerative colitis, Crohn's disease, microscopic colitis, and divergent colitis, as I have told you. Well, moving on to the microscopic colitis. In microscopic colitis, there will be majority the disruption of the intestinal wall due to the long-term use of proton pump inhibitors and NSAIDs, which is non-steroidal anti-inflammatory drugs. And when you will use this, there will be decreasing in the gastric juice secretion. There will be increasing in the permeability of the cells. Whenever the permeability of the cells will increase, what will happen? The bacterial overgrowth will move inside the walls of the intestine and it will lead to this type of diseases, this microscopic colitis. And what are the clinical features? There will be chronic, non-bloody, voluminous, watery diarrhea, which is similar to small bowel diarrhea. And then you will see the clinical examination will be normal. The endoscopy will be normal, but the biopsy you will see two patterns, which is collagenous colitis and lymphocytic colitis. This collagenous colitis, you will see presence of collagen band in the mucosal layer and it is associated with Sjogren syndrome. The Sjogren syndrome has the basic features which will be decreasing in the secretion and all. Then there is lymphocytic colitis, where the intraepithelial lymphocytes are involved and it is associated with the celiac disease. The basic symptoms which are present in the celiac disease will be present in the lymphocytic colitis. After that, the divergent colitis. What is divergent colitis? It will basically occur in the patient which has presence of choliostomy packs. What is choliostomy pack? Imagine this: if you have full intestine, what if you already have a full intestine? The proximal part and the distal part is affected, but the proximal part is fit and fine. The distal part might have presence of bacterial overgrowth, might have presence of ulcers, but in the proximal part it is good. So we will have a cut section. We will bring the proximal part which is not affected outside the stomach, and if it is brought outside the stomach, the stool which is getting created, it will pass from the stomach part. It will be collected in a choliostomic bag. So in this patient, the divergent colitis is basically a common thing. Look, after surgery for bowel malignancies, some normal histology of colon, the inner layer to outer layer, but I have learned from outer layer to inner layer, so I will be going with that. The first is serosa, muscularis, submucosa, and mucosa. These are the basically major four layers present inside the colon. So you can see here it is given more. So they are the between layers present in this. The mucosa of colon, point to be remember, has absence of villi. Villi are absent there, but the crypt will have presence of microvilli which will help in the absorption of water. So microvilli are present which will help in the absorption of water. Then there will be goblet cells present. Goblet cells, the primary function is to secrete mucus. And then there will be moving on to epidermatology of ulcerative colitis and Crohn's disease. What is ulcerative colitis? What is Crohn's disease? Basically, they are the immune responses which will lead to inflammatory bowel disease. In ulcerative colitis, males are affected in Crohn's disease, majority the females are affected. Why the females are affected more? Because of the overuse of OCPs, oral contraceptive pills such as I pills, ILE. So here, this Crohn's disease has females more affected as compared to males. But in ulcerative colitis, males are affected more as compared to females. Age. What is the age peak? 15 to 30 years, 70 to 90 years. These are the age peaks where the patient might have causing ulcerative colitis as well as Crohn's disease. So look, here are the peaks. They are the same. Ethnicity. Ethnicity first the most affected peoples from the ulcerative colitis were Jewish, then non-Jewish white, then African American, then Hipsis, then Asian. But in Crohn's disease, the most affected people were Spanish, the people who were belonging to Spain. Then smoking. Smoking will act as protective agent in ulcerative colitis, but it will act as causative agent in Crohn's disease. Why it will act as protective agent in ulcerative colitis? Just because the presence of nicotine. The nicotine will go and bind to the nicotinic receptor. If the nicotinic receptor is blocked, it will decrease the inflammation. And if the inflammation is decreased, the ulcerative colitis is basically getting an symptomatic treatment, it is getting cured. But what is happening in Crohn's disease? This nicotine will go and bind to the nicotinic receptor on which the medicines of this Crohn's disease might have binded. So there will be a constant competitive inhibition going on there. And if the medications of the Crohn's disease are not binding properly, it will worsen the condition of Crohn's disease. And the same thing is happening here. So that's the reason this smoking is causative agent in Crohn's disease. Then the next point is appendectomy. In appendectomy, it will act as protective agent in ulcerative colitis, but it is not associated with Crohn's disease. In ulcerative colitis, it will act as protective agent because the appendix has presence of microorganisms. If the appendix is removed, the microorganisms cannot go and stay there, and this will be helpful for ulcerative colitis. Then OCPs, oral contraceptive pills, there is no risk in ulcerative colitis, but there will be high risk in chronic disease. In familial inheritance, what will happen? Whenever the genes are passing from one generation to another, the risk of getting Crohn's disease is more as compared to getting the risk of ulcerative colitis. And in the pediatric thing, what we can say, if there is increase in the use of antibiotics within 1 year of lifespan, then the child is suffering from the risk of causing IBD by PX. 3x is too much. Here, doctors will do this thing. They want to cure their patient, they will start giving antibiotics in less than 1 year. But in long term, it will cause a very defective thing that is increasing in the risk of IBDs. We'll move on to the note points. What are the note points? Beckett's disease. Beckett's disease basically it is just a mimication of Crohn's disease. Look, GI manifestation like Crohn's disease. And they both will share the same antibiotic, which is anti-Saccharomyces cerevisiae antibiotics. This is a this is a bacteria and fungus, Saccharomyces cerevisiae. So prolonged use of alpha-methyl dopa causes features similar to ulcerative colitis. Alpha-methyl dopa it will cause same features. Campylobacter jejunum is a factor for IBD, inflammatory bowel disease. Campylobacter, they are learned in microbiology. Then genetic syndrome associated with IBDs. First, ulcerative colitis is majority non-granulomatous and Crohn's disease is granulomatous. These granulomatous and non-granulomatous, these are just fancy names for acute inflammation and chronic inflammation. So non-granulomatous is basically acute inflammation and this granulomatous is basically chronic inflammation. In ulcerative colitis, non-granulomatous disease, there will be Turner syndrome, which is most common. Then there will be Wiskott-Aldrich syndrome. In granulomatous von Gerke's disease, this is the glycogen storage disorder we have learned in biochemistry. And Hermansky-Pudlak syndrome. First, we'll move on to the clinical features of this genetic syndrome. First is Wiskott-Aldrich syndrome. Here, the VASP gene is detected, and this is X-linked recessive. You will see recurrent sinopulmonary infection. You will see schizema. Schizema is basically the gym boys which are going to the gym. You can see that You can peel off the palm skin due to lifting of heavy weights. So in this disease, the if you are not lifting heavy weights, still you can peel off your skin. So that is eczema. Then there is recurrent thrombocytopenia. The platelets will increase largely, and the next is Hermansky-Pudlik syndrome. This is autosomal recessive disorder. Here, platelet dysfunction with normal platelet count. Platelets will have dysfunction. They will disrupting shape. They will not act properly. They will not do their work. But the count will be normal. So that you will see in Hermansky-Pudlik syndrome. Then there is intestinal lung disease, interstitial lung disease, that is pulmonary fibrosis. You will see dead tissues present inside the lung. And then there is oculocutaneous albinism. In oculocutaneous albinism, you will see loss of melanin in hairs, in eyelashes, in skin, and in eyeballs. Then we'll be moving on to von Gerke's disease. Von Gerke's disease is basically a glycogen storage type 1 disorder. Here, the enzyme which is affected, which is less, is like glucose 6 phosphatase. It will lead to many clinical manifestations like doll-like face, seizures, hypoglycemia, hepatomegaly, lactic acidosis, hyperuricemia, hyperlipidemia. The next thing is PTEC syndrome, which is immunopolyendocrinopathy X-linked syndrome. In this, what is the pathology of this syndrome? Here, the FOXP3 gene is present. FOXP3 gene. This acts as transcribing factor, and this is important for regulation of T cells. The regulation, what regulation? The tolerance capacity, the cell tolerance capacity, basically. Then there is, if there is loss of FOXP3 function, the cell tolerance will decrease and it will lead to IPEX syndrome. What is the triad of IPEX syndrome? What are the symptoms? You will see. First is the dermatitis. Then there is endocrinopathy. And then there is ulcer-like enteropathy. You can see here. The management for IPEX syndrome is okay. The gene is affected. So basically, what you will do, you will do gene therapy, gene treatment. So gene therapy, gene replacement, supportive care. That is just the management. And in investigation, you will do gene testing. And in gene testing, which marker will be tested? You will test CD3 marker, CD4 marker, and CD25 marker. In early onset childhood IBD, there will be defect in interleukins, interleukin 10, or if the receptor which has interleukin 10 is affected, it will lead to inflammatory bowel disease in the early age. Look, here it is written there. Because the most potent anti-inflammatory cytokinin is interleukin 10. That's the thing. And pathogenesis of inflammatory bowel disease. What is the pathogenesis? So basically, two factors are affecting them. First is the exogenous factor, then there is endogenous factor. And endogenous factor, basically the genes, the genetic factor, and the immune factor will be affecting this thing. And in exogenous, smoking, oral contraceptive pills, they will be affecting this inflammatory bowel disease. So in genetic factors, such you can see here NOD2 gene, and in immune you can see interleukin 10, interleukin 12, interleukin 17, interleukin 23, and the TNF alpha, as well as cytokinins. This will be there in this endogenous factors. So first we will see the pathogenesis of ulcerative colitis. What is the pathogenesis of ulcerative colitis? So the pathogenesis of ulcerative colitis I can't teach you because it is not yet discovered. The pathogenesis of ulcerative colitis is unclear, but we can just predict that there will be overaction of adaptive immune system, that is T helper 2 lineage. If there is T helper 2 lineage, you can say that basically the patient might have been suffering with ulcerative colitis. In Crohn's disease, this NOD2 gene which is present on, I will tell you just the pathogenesis. The NOD2 gene which is present on chromosome number 16, which is responsible for tolerance regulation of T helper cells. This is getting affected. Now, the T helper cells are not basically regulated, and they cannot distinguish between the own cells and the enemy cells, and they will start destroying this thing. It will involve cytokinins, TNF alpha, and interleukins. Interleukin basically 10 and interleukin 23, 17. This will be involved. So, if this gene is affected, there will be dysregulation of the mucosal immune response. There will be defective innate immunity. If the innate immunity is defected, the clearance of the microorganisms will be hampered. Look, the decrease in the clearance of the intercellular organisms like Mycobacterium paratuberculosis and Mycobacterium avium complex. They will just enter inside the cells and start disrupting the system. Then there is decreased defense production in the panic cells. Panic cells is basically responsible for the secretion of IgA antibodies. If IgA antibody is not secreted, these microorganisms can get a full clearance. They will get inside the system and they will start disrupting it. Then there is defective autophagy. Autophagy is basically whenever the cell is affected or defected, it has a suicidal bags called as lysosomes. It will fully engulf the cells. But what will happen in this? There will be defect in autophagy as well in Crohn's disease. So you can see lesions present inside the intestine because the cells which are affected they are not getting engulfed by their own. So you will see some lesions there. We'll talk about this later. There is overactive adaptive immunity of TH1 lineage. So here ulcerative colitis you have seen TH2 lineage. In Crohn's disease you have seen TH1 lineage. Decreasing in the gut bacteria like Faecalibacterium. This Faecalibacterium, this is gut protective. This is gut protective basically. If this bacteria is decreased, so there will be disruption of the full gut. After that, pathology of ulcerative colitis. The first thing you should be remembering that in ulcerative colitis, you will see the affected part will be mostly distal part, which is rectum, sigmoid colon, and small part of terminal part of ileum will be involved there. So rectum 50% it will be affected. Then it will extend to sigmoid colon, which is 30 to 40% affected. Then it will move on to the ileum. Ileum involvement will be very less, like it will only just 10 to 20%. We will see the macroscopic features. What are the macroscopic features here? There will be superficial, continuous, symmetrical lesions present. I told you lesions are present because there is no autophagy. Autophagy is lost here as well. So continuous involvement of rectum, sigmoid colon, and ileum. No skip lesions. You will basically see lesions all over the part. The first change you will see erythematous mucosa with fins and granular surfaces, hemorrhagic idiomatous ulcerated mucosa, and pseudopolyps, inflammatory polyps due to epithelial regeneration. You will see basically like this polyp-like structure there. And after, if there is chronic, long-standing ulcerative colitis, it will show you lead pipe appearance. What is lead pipe appearance? Basically, you will see here there is presence of intestine. It is intestine. So it has presence of this structure called as hostera, and here it is presence of tinea solium and hostera. Tinea, sorry, not solium. Tinea and hostera. So this hostera will have deposition here, deposition inside, and it will look like a full grown pipe. So this is called as the lead pipe appearance. It will be swollen and the inner part will be narrow. It will be swollen and the inner part will be narrow. These are the microscopic structures. Then we will move on to the microscopic structure. There will be in microscopy there will be superficial involvement of the mucosa, superficial part of the submucosa. The crypt will lose its architecture. The Paneth cells is called metaplasia, and basal plasma cells and lymphoid will start aggregating. And that's it about the microscopic structure. There are just four structures. You just need to decide them that there will be superficial involvement of mucosal there and the submucosal part. Then the architecture of the crypts will be lost. Then the parent cells will get metaplasia, and then the basal plasma cells and lymphoid aggregations will be seen there. That's it. The factors against the ulcerative colitis. Look at this thing. These all factors are present in the ulcerative colitis, but as well as they will be present in other disease. So you can't say that if these features are present there, that the patient is suffering with ulcerative colitis. They might be suffering with the other diseases as well. So what are these factors? You will see transmural involvement, skin lesions. Skin lesions you can basically see in various diseases. A lot of diseases will show you the skin lesions. This transmural involvement, many diseases will show. Deep ulcers, not only in the ulcerative colitis, you will see this in Crohn's disease as well. So thickness, structure, features, fistulas, fibrosis, abscess, everything can be seen in other diseases as well as per the ulcerative colitis. And that's it about this. And we'll be moving on to pathology of Crohn's disease. So, in Crohn's disease, the first thing you should be remembering that everything can get affected in the gastrointestinal tract as per the Crohn's disease. From mouth to anus, everything can get affected. So here it is written can occur anywhere from oral cavity to anal canal, perianal involvement. So in ileocolitis, like inflammation in the ileum, it will cost 40 to 50%. Ileitis in ileum, it will cost 30 to 40%. In colon, it will cost 15 to 20%. Microscopic analysis, you will see deep transmural asymmetrical skin lesions. Skin lesions, look here also skin lesions are present. They were present in ulcerative colitis as well. We can't say that the skin lesions are hallmark for anything. After that, early finding aphthous ulcers, small and translucent, and these aphthous ulcers are non-contagious basically, non-contagious. Then most visible finding is linear and spagheous ulcers. The spagheous ulcers are contagious. These things should be remembered. Cobblestone-like appearance. Cobblestone-like appearance. Basically, you will see here this type of appearance. Like some stones are big, some stones are small. Not stones. There are skin lesions present there. So this will show you the cobblestone-like appearance. Then perirectal features, fissures, fistulas, and abscess will be seen. This fistulas traces revolve by fibrosis, thickness of wall, and stretches. You will see very thickness of wall. Due to this thickness is due to the presence of crippling fat. This fat which will go and deposit into the mesentery enhancing the bowel wall. And garden horse appearance, basically you will see the whole hollow pipe. You won't see lesions, you won't see anything, you will just see the hollow pipe. That is garden horse appearance there. Then there is microscopic analysis. In microscopic analysis there will be transmural involvement up to the muscular propria. Then there is a non-caseating granuloma. Non-caseating granuloma is the hallmark for this disease, but sometimes it is not seen, and it is also seen in various diseases as well, but still it is considered as the hallmark. Then there is mesenteric lymphadenopathy, and there will be crypts. Crypts will have cryptitis, rolling of crypt. There will presence of abscess inside the crypt, but the architecture of the crypts will be safe. It is written here. Crypts abscess and the crypt architecture will be normal. You can see this microscopic analysis in Crohn's disease. Then there will be pyloric metaplasia, increasing in the cell size, increasing the cell number, that is metaplasia, hyperplasia. And all. There will be lymphoid aggregations and the causes of non-caseating granuloma. So you will see this non-caseating granuloma in sarcoidosis, tuberculosis, cat scratch disease, pylorosis, hypersensitivity pneumonitis, and Crohn's disease as well. So it is considered as the hallmark. You should be remembering this. This is for today, and we will be starting with the next lecture with the inflammatory bowel disease part 2. And only 4 to 5 lectures will be present there. After that, we'll be completing the gastroenterology, and we'll start with the next section.
Free audio post production by alphonic.com.